Yeah, ma'am, you can start. Thank you. Thank you. Hello, Anjali ma'am. You can start now. Thank you.
Good evening, everyone. Namaskar, and welcome to Pediatrics. And today we have a whole lot of interesting cases. We are first going to start with epidemiology because Dr. Kishore Chavan, who is the WHO consultant for VVCMC, has to leave for some urgent work. We can understand that. And then we are going to have Dr. Lalit Verma with expert comments from Dr. Shruti Bajaj. We're going to have a second case from Dr. Vaishali More, again with expert comments from Dr. Shruti Bajaj. We're going to have Dr. Rajiv Sinha and Dr. Gaurav Chaubal. So these are our stellar speakers for today. 28th of February every year is marked as Rare Disease Day, and February is celebrated as Rare Disease Month. And with so many common infections now, about which we are going to speak in the end. Before that, we are going to take some rare diseases. But before we do all that, we are going to begin with Dr. Kishore Chauhan. Dr. Kishore Chauhan is a WHO consultant for VVCMC. He collects data, collates data, and creates all kinds of data for us, the logistics on patients of measles, rubella, those fever with rash, and also those with acute flaccid paralysis. He gives us a monthly update every time, and today he's going to give us a monthly update on what's happening in the VVCMC area of Vasai Virar Nalasopara. So over to you, Dr. Chauhan.
Thank you, madam. Madam, I'm unable to share the screen. It is disabled.
Yes, sir.
Yeah, got it. Got it. Yeah, got it. Is it visible, madam?
Yes.
Dr. Pallavi?
Yes.
Yeah, full screen. It is full screen?
Yes, sir. It is full screen and it is visible
okay.
also.
Okay, yeah. Thank you. Good afternoon, everyone. Good afternoon, everyone. This is a small presentation on update on measles, polio, diphtheria, pertussis, tetanus, and AEFI. It's just 10 to 12 minutes. These are the topics. Measles, rubella. The cases are more in Central Africa, some Southeast Asia, and even the rubella case Central Africa and some Southeast Asian countries. If you look at the global scenario of the elimination of measles and rubella,
Dr. Kishore,
out of 194 countries, 81 countries have eliminated measles and 93 countries eliminated rubella. American countries, almost all countries, they have. Yes, madam. Yes.
तुमचा video
आवाज break होता है?
तुमचा video off
madam,
करा.
आवाज break होता है?
हो.
Okay.
Video off करा म्हणजे हाँ.
Just a minute. Okay. Video off किया madam. Am I audible now?
Yes, very well.
Okay. Most of the American countries have eliminated rubella and measles both, and all African countries are still yet to eliminate measles and rubella. All 47 countries, measles and rubella still present, and other regions they are variable. And in European countries, almost they have also eliminated. Western Pacific, very few have eliminated. Eastern Mediterranean, like Pakistan, Saudi Arabia, only 3 countries have eliminated in that area. Coming to our VVCMC. we had 13 measles cases in 2020, 3 cases in 21. Madam, am I audible? Madam?
Yes. Yes.
Dr. Pallavi, am I audible?
Yes.
Yes, sir. You are audible. You are
Dr.
audible.
Yogita, आपला mic चालू आहे. Yeah.
Yeah.
Dr. Yogita's mic on आहे मला वाटतं.
मी म्यूट केलाय सर. केलाय मी म्यूट.
Okay. Okay.
Dr. Jaya Jawan.
There were 13. Yes, ma'am. Okay. 20 मध्ये 13 cases होत्या. 21 मध्ये 3 cases, and last year in 22 we had 104 measles cases. But rubella we had 1 in 20. In 2020 with 5 cases, and last year we had 8 cases. In Palghar district also, we had very few cases.
किशोर तुमचा ऑडिओ बरोबर नाहीये.
We didn't get a positive measles outbreak last year. So that the immunization is very good in Palghar district. Rubella cases sporadically occurring in almost.
I think sir out झाले madam.
Oh, we'll give him some time to
Yes, ma'am.
back.
Yeah. ma'am.
Yeah, and I think
Then-
there are.
Then we,
Want to say something?
till then today is Women's Day, so we'll talk a little bit on Women's Day, I think.
Please do that.
Yeah, till Sir joins in. Yeah, a lot of
Happy Women's Day.
happy
Women's Day
Women's
to
Day
everyone.
to all. Yeah, yeah.
वैभवी तुला काही 2 शब्द वुमेन्स डे बद्दल बोलायचंय?
Okay, yeah. So today is good afternoon, everyone. Today is International Women's Day, and since morning we are receiving a lot of messages on the WhatsApp for Women's Day. So this Women's Day was celebrated on March 8 as an International Women's Day. It is a global event that celebrates and appreciates the efforts and contributions of women in forming and balancing the society. Also, the special day aims at celebrating the contributions and achievements of women across the globe in political, social, economic, and cultural domains of the society. This day was first celebrated on February 28th in 1909. That is a century back in New York, which was organized by the Socialist Party of America. Then in 1910, the International Women's Conference was organized, in which it was proposed to establish the Women's Day to appreciate the love and sacrifices of women all over the world. And now this year, the theme of International Women's Day is Digit All. That is innovation and technology for gender equality. The purpose of this subject is to acknowledge and appreciate contributions that women and girls are making to technology and online learning. And we are very fortunate that our digital partner is also a woman, Miss Pallavi Dharmadhikari. So great applause to Madam for her contribution towards the digital media. And our digital Palghar Academy had also started the Zoom webinars way back 2 years back in the COVID state. It was by Dr. Jayashree Deshpande, and since then we also have started learning the digital media. So even our women, means we were not so initially aware of the technology and everything, but now slowly we are also getting to know all the technology. So that is the woman empowerment. And our Palghar Academy is more of women members. So a great applause to everyone. Yeah. And I congratulate all the women on the dais and all the other people for working so hard. It is very difficult to manage the home, the social environment and everything and do such beautiful work. Thank you. I think Kishore sir has come back. Yes, sir. And we go on to Dr. Kishore Chavan. Yeah.
Yeah, Kishore, you can carry on from where you left.
No, I think sir is still.
त्यांचा network बरोबर नाही.
He is still connecting, ma'am. Though we are seeing that he is connected.
Okay. Yeah.
Pallavi madam, thank you on this Women's Day.
Yes, ma'am.
For,
Same to you.
yeah, joining us, Palghar Academy.
Definitely.
Yeah.
It is my pleasure and pride to connect with Palghar Academy. Thank you. Thank you all.
Thank you, Pallavi. Anuradha, will you call up Dr. Lalit Verma in the meantime? And I think we can start with our second case first, because मला वाटतं Vaishali More, Dr. Vaishali and Shruti. तोपर्यंत मला वाटतं Lalit Verma.
I am ready.
Yeah. Okay. So let me.
Shruti is around.
Yeah, Shruti, hi. Let me introduce this to, I think it's only befitting International Women's Day that two women start the ball rolling. And with that, we have Dr. Vaishali More. We have often heard her talk about urinary infection, nephrotic syndrome, as well as nephritis and hematuria, proteinuria. But today she's going to talk about a very rare renal disease. As you all know, Dr. Vaishali More is a practicing pediatric nephrologist in Vasai, Virar. We are very fortunate that she visits us very often, twice a month. And all our patients are taken care of by her. For the last 10 years, I believe she has been coming over here. And she also practices in Mumbai, SRCC Hospital. And she has taken up a post in D.Y. Patil College as a professor. So with her today to make special comments on genetic disorders of this case, we have Dr. Shruti Bajaj. Again, we are so blessed to have such qualified ladies visit us. Shruti Bajaj is a clinical geneticist, and she has been visiting Vasai Virar area for the last 8 years. And she also has her own clinic at Malad. She visits Vasai and Virar once a month. She also has satellite clinics in various other cities. With this, we'll go over to Dr. Vaishali More. Yes, Vaishali, please carry on.
Thank you so much, ma'am, for allowing me to participate today and present this case. And thanks, Shruti, for being there to discuss the genetic report. I think you all can see the screen that
Yes.
I'm sharing. And
Yes,
I think I'll stop my video so that my voice is clear.
Yeah.
Thank you. So since we are celebrating the rare disease month, I thought I'll present a case which only 101 cases have been reported worldwide. Give me 1 minute. So this was a 17-year-old male child who presented with fever, weakness, and body ache since 1 day. He also had history of repeated headaches since 1 month. There was no history suggesting any cause for this particular headache. Like he did not have repeated episodes of cold or caries or ear discharge. There was no history of any convulsion also. On general examination, he was stable. He was afebrile. There was no pallor or icterus. His heart rate was 86 per minute with a respiratory rate of 22 per minute. Blood pressure was 180/90 and SpO2 was 98%. If we look at the anthropometry, his height was 5 feet, weight was 61 kg, and his BMI on calculation came to 27.1. So he was little overweight, but then it was not looking like a cause for that particular hypertension that he had. On systemic examination, he had no other abnormality. On investigating him, the child showed a CBC of 7,800 with neutrophils of 66% and lymphocytes of 39%, and platelet count was 2 lakh. Blood urea nitrogen was 23, creat was 0.9. 0.9 is for a 17-year-old still a little on the higher side. Serum electrolytes when done, the sodium was 139, potassium was 2, and the chlorides were 93. Now hypokalemia, and then as you can see here, multiple reports are showing that there is persistent hypokalemia. Now, what is the cause for this hypokalemia? There was no GI loss. So then it comes down to whether there is renal loss. What about hypochloremia? In the first two reports, when you find it is less than 95, then it is hypochloremia. So were there loop diuretics? No. Was NG suctioning being done? No. Then metabolic acidosis, we'll look at that. And whether the hypertension is explained by the overweight? No. So this is a child who is having hypokalemia and who is having hypertension. So what are the causes? So first we said that either there could be increased losses, which can be gastrointestinal losses in the form of vomiting, diarrhea, or fistula, or there could be renal losses. Decreased intake could be a cause which was not there in our patient. Transcellular shifts could be causing this, like alkalosis, hypomagnesemia, hypernatremia, GI drip which had not been given, DKA was not there, and refeeding syndrome was not applicable here. At the same time, none of these drugs were being given. Sampling error is a possibility, but then we have seen that it was persistently low. It was not that only one report was abnormal and the rest were normal. So the VBG, what did it show? It showed us a pH of 7.46 and a bicarb of 32. So there was metabolic alkalosis. So we did a urine potassium and that was more than 50. On retrospectively asking for history of polyuria, polydipsia, he did give history of polydipsia, though he was not getting up in the night to pass urine. He was getting up in the night because of thirst to drink water. Now look at this chart. This is one way of approaching a patient with hypokalemia. So we do the urinary potassium level, or you can do 24 hours, or you can do urine potassium creatinine spot test. So if you are finding that there is conservation happening, that means it is on the lower side in the urine, then it is a different story. Then there are GI losses or hypokalemic periodic paralysis. But if on the other hand, you're finding that there is loss happening in the urine, like in our patient, and there is presence or absence of hypertension, you divide the patient into two categories. If there is hypertension, then we have to do what is plasma renin activity and plasma aldosterone concentration. Now, if both are high, then there is secondary aldosteronism, renovascular hypertension, or a tumor in the kidney. If the renin is low and the aldosterone is high, then primary aldosteronism, glucocorticoid remedial aldosteronism. If both are low, then we should look at the serum cortisol level. If cortisol is high, then in that case, we go down to Cushing syndrome or ectopic ACTH secretion, or apparent mineralocorticoid excess, or licorice ingestion, what is called as Jeshtamad in Marathi. High serum cortisol is absent, then we think about Liddle syndrome. Whereas in the absence of hypertension, look at whether there is acidosis or alkalosis, then look at the anion gap and the urinary chlorides. If the anion gap is normal, then it is RTA. If the anion gap is not normal, then diabetic ketoacidosis, which your sugars will also tell you. If the urinary chloride losses are happening, then diuretic abuse, Barter's syndrome, or Helix and East syndrome. If they are not happening, then gastric fluid losses should be considered. The other approach is just from the metabolic alkalosis point of view only. You can look at the urinary chloride again. It is just a highlighting of one particular part of the previous flowchart that we saw. So in the presence of hypertension, congenital adrenal hyperplasia, Cushing's disease, Geller's syndrome, hyperaldosteronism, Liddle syndrome, renovascular disease, renin secreting tumor, and apparent mineralocorticoid excess. So our patient had a PRA which was low, the aldosterone was also low, and the cortisol was high for his age group. The other investigations that can be done is the urine tetrahydro cortisone and tetrahydrocortisol. The ratio, this is basically excretion of cortisone and cortisol in the urine. So the ratio, these will be on the higher side. So what did the ultrasound show? We could not do these investigations because they were not available to us. The ultrasound showed us that there were slightly echogenic kidneys, but they were normal size. So there was no primary renal pathology to cause the hypertension in the form of small kidneys or CKD. The Doppler which was done showed that there was no renal artery stenosis. A 2D echo was done that showed concentric left ventricular hypertrophy, which is suggestive of end organ damage coming up because of the hypertension. That means this high blood pressure was not something which was acute, but this is a long-standing hypertension. So this is the genetic test report of the patient. Dr. Shruti, would you like to comment here or at the end? I think I will just say that it did show apparent mineralocorticoid excess, but it did not show that it said that it was VUS, means variant of uncertain significance was reported. They reported this way because they usually, if that particular mutation has not been reported in literature before, then they have to report it as VUS. I think Dr. Shruti will put more light on that. So let us see what exactly happens here. So this particular enzyme, 11-beta hydroxysteroid dehydrogenase 2. Yeah, Shruti, you're there? (11-beta hydroxysteroid dehydrogenase 2 is responsible for conversion of cortisol to cortisone. And cortisone is the inactive form. Cortisol is the active form. What happens is this enzyme, if it is deficient, like in our case, then a lot of cortisol is there in circulation. It goes on stimulating the mineralocorticoid receptors. And because of that, there is the whole pathophysiology of loss of electrolytes and hypertension, which is happening. It is a rare disease. As I said, deficiency of 11-beta hydroxysteroid dehydrogenase, which converts cortisol to cortisone and prevents the mineralocorticoid receptor from activating by circulating cortisol. Only 101 cases have been reported till 2020. If we look at the classification, our patient falls in the classical type of apparent mineralocorticoid excess. They had a higher blood pressure. There was history of polyuria, polydipsia. The pre and postnatal growth failure, we did not find any evidence. Hypokalemia was there. Both plasma renin as well as aldosterone activity was low. The rest of the investigations we have not done because they were not available, as I said. So what is the way in which to treat them? First and foremost, you have to control the hypertension, because this is all hypertension which is going to cause the further damage to the kidneys, as well as they can have cardiovascular accidents. So what to use? We have to use something which will block the mineralocorticoid receptor, so antagonize it. So spironolactone should be used, and potassium supplement should be given to correct the hypokalemia. So what happens in these patients? So whatever little is available, we know that renal failure can happen in 15%, cardiovascular accidents in 19%, and nephrocalcinosis in 89%. The cause for this particular nephrocalcinosis is not really very clear, but it is said that long-standing hypokalemia can cause interstitial fibrosis, which causes ammonia genesis locally, and because of that, dysfunctional calcification can happen. That is the only available explanation for nephrocalcinosis. Now, right now, our patient on spironolactone is having a blood pressure which is under control, less than 120/80. He was diagnosed in July last year. So now we are like, say, 8 months. And potassium is maintained at 3.8 to 4.1. He's completely asymptomatic. All his headaches have subsided. He's going to college and attending it on a regular basis. I would like to acknowledge Dr. Shailesh Barot sir, Dr. Suresh Sonavne sir, and Dr. Shruti Bajaj also. Barod sir, this patient was basically admitted with Dr. Sonavne sir, and Barod sir was the first person to go and see the patient when he was referred. And then I came into the picture. So, and then Shruti has done a wonderful job of counseling the parents. So thanks to all of them. Also, my warm regards to all of you, to the wonderful team of Palghar. Happy Women's Day, because today is Women's Day, and on the eve of World Kidney Day, I also wish you a very, very happy World Kidney Day. Thank you.
Thank you so much, Vaishali, and we'll get Shruti to comment.
Yeah, so thank you, Dr. Vaishali. Thank you, Team IIP Palghar. It was a wonderful case. I think few take-home messages which I would want to highlight over here. This was one case, which was a rare case, and we often see and we often repeat that rare is many. Rare disorders are not as uncommon as we think. One of the ways to pick it up, the way Dr. Vaishali and the way Barod sir thought, was surprising lab values. Not getting what you would have normally looked at in a non-genetic scenario. So these surprising lab values or extreme pathology, hypertension in a very young child without any evident reason. While we have picked up this case, how to not miss other cases by looking at common patterns, that was one thing. Second, I think we have forayed now into an era where genetics are being ordered more easily. So we don't need to necessarily tell when to order, but when the test has come in front of us, how to make sense of it. If you notice the report that Vaishali doctor had shared, it was in the rightmost column written, variant of uncertain significance. Now, while in this case, the uncertain significance seems to match this as an entire spectrum in itself, because uncertain variants are those variants which do not qualify to be pure pathogenic. And 2/3 of these will get downgraded to being benign. So as clinicians, our caution to not take every genetic report as the holy grail and to question it, to collaborate with experts to know how much into certainty are we and how deep can we go based on a particular report. These are my only two comments, madam, which I want to share. Yeah.
Excellent. And so we have a rare disease on the eve of World Kidney Day, and on Women's Day, 2 women presenting and opening the talk. So nothing could be more apt for our session. And it's so happy that we had Dr. Kishore Chauhan to start, but it was deigned that the ladies should start first. So that's as far as my comment goes. But thank you very much, Vaishali. Thank you, Shruti. And all the very best for rare disease and for World Kidney Day as well.
Thank you, ma'am.
With that, we have Dr. Kishore Chauhan. Dr. Kishore, can you go ahead with your rest of your presentation?
Yes, madam. Am I audible, madam?
Yeah.
Yes, sir. Yes, sir. You are audible.
Okay. Thank you. Yeah, we had 3 deaths because of measles in last 6 months. And Palghar is the one district where we did not get any measles outbreak because immunization coverage is very good there.
So sorry to interrupt. Have you shared the presentation? But it is
I'll share it.
Visible. It is not visible, sir.
Not visible?
No, sir.
Okay. Just a minute. Now is it visible, madam?
Yes, sir. Yes, it is visible.
Okay.
Just make it full screen.
Yeah.
Yes, it is full screen.
Yeah.
Thank you, sir. Thank you.
As far as measles eradication is concerned, they have given us 2 indicators that we call it a non-measles, non-rubella rate, and our immunization coverage of MMR2, that is at 15 or 16 months, should be more than 25% children. So they should be immunized. And for the have given the definition of for the fever rashes. Any person with a fever and maculopapular rash to be reported as fever rash cases or suspected measles case. In 2021, we had reported 117 cases. In 2022, we have reported 300 cases. Our non-measles, non-rubella rate should be more than 2. It was more than 4 in 2021. And in 2022, it was 5.83, which was very good. So it is a good indicator of searching of all the measles and rubella positive cases. Another indicator they want is immunization coverage should be more than 95% for MCV2. So that is, it is here, it is only 90%. And full immunization coverage is only 92% in the Vasai Virar Corporation. And MCV1, that is at 9 months, it is at 93%. All these three indicators should be more than 95%. Then it's generally stops the virus transmission in that area. Here, the coverage is very good, but there are pockets of infection coverage. For example, Dhanu UPSC area, MMR rate is only 75%. Patankarpar, only 92%. Palghar UPSC, only 66%. So we got death cases in only Dhanu and the Palghar UPSC area where the immunization coverage was very, very low. So we are trying our level best to increase the coverage in these areas. If you look at the dropout rates of the, let's say, Penta-1 or Penta-2 vaccine, the 3.5% dropout rate in the those who are coming for the Penta-1, 3.5% will not come for the third dose of the pentavalent vaccine. So, but these are the few health posts or areas where the dropout rate is very, very high because of certain reasons like adverse event following immunizations. Those are not being properly dealt. These vaccines are being given to the children. Any adverse event occurring after that not being dealt, not being addressed by the
किशोर तुम्ही व्हिडिओ बंद ठेवा.
only 80%.
डॉक्टर किशोर तुमचा ना बँडविड्थ लो आहे, तुम्ही व्हिडिओ बंद ठेवून फक्त ऑडिओ चालू ठेवा.
Okay. Hello, madam.
हा बोला ना.
Hello.
हा हा सर तुमचा प्रेझेंटेशन बंद झालंय. प्रेझेंटेशन चालू ठेवा.
I think there's some problem with my. There's some problem. कमी आहे इकडे. There's some problem with my internet connection. I'll finish up in 2 minutes. Huh?
Okay. Okay.
Am I audible now?
Yes.
Yeah. Okay. When we categorize this full immunization coverage in the non-Muslim and Muslim population, so in Muslim population, it is just 80%, which is very, very low. This particular percentage will not stop the transmission of the virus, right? Similarly, we did in the Palghar UPSC area also. There also, the fully immunized children are trying very, very hard to target all these four health post areas to improve the coverage. Another disease, polio. This is our last case in 2011. 12 years have gone, but still the polio is not eradicated from the world. There are no cases in India for last 12 years. But in the Pakistan and Afghanistan, still the virus is there. From there, the virus has spread to Mozambique. There it has spread. Last year, there were 20 cases in Pakistan, 1 in Afghanistan, and 8 in Mozambique. The definition of eradication for 3 years, if there is no case, then only we can say it is eradicated, but the virus is still there in 2 countries. Until they finish up their virus, the polio can't be declared as eradicated. We were supposed to conduct the pulse polio immunization in the month of Jan or Feb, but because of measles outbreak was postponed, the date is not been declared yet. In AFP surveillance, we need to report all the cases below 15 years of age, those who are having the sudden onset of weakness or floppiness in any part of the body. These are the conditions we are generally report for the AFP cases, like suspected cases, poliomyelitis, transverse myelitis, GBS, post-diphtheric polyneuritis, paraplegias, quadriplegias, isolated bulbar paralysis, isolated neck flops, viral neuritis, post-injection paralysis, placid hemiplegias, monoparesis, wrist drop, foot drop, transient paralysis, or any acute illness paralysis which are non-traumatic. We had reported 30 AP cases, so at present is AP rate is more than 10, which is very, very good. In case the virus enters into this kind of surveillance. In the DPT surveillance, the new thing has been observed. The diphtheria cases, we were getting few cases. Pertussis cases, we 19. But in other corporations, this year in 2023, we got 3 cases in Bhiwandi Corporation, 4 cases in Ulla, 2 cases in 2 cases of pertussis in Thane, and in Navi Mumbai. So this is how the pertussis cases are being increased in certain areas. And you cases are not AFI cases, that adverse event following immunization. It is very, very important for us, because wherever these AFIs are occurred, and if they are not addressed properly, this will create the refusal among the community, and this will go on increasing, and they refuse the vaccination later on. And these are the conditions to be reported after vaccination, like anaphylaxis, persistent inconsolable screaming, hypotonic, hyposensitive, hyporesponsive episode, toxic shock syndrome, several severe local reactions, sepsis, injection site abscess, seizures, including febrile seizures, encephalopathy, brachial neuritis, intussusception, lymphadenitis, disseminated BCG infection, osteitis, osteomyelitis, death, hospitalization, disability. These conditions have to be reported as AFI, so that we discuss about it and then categorize as not because of the vaccine. These are the AFI committees at the various corporation areas. Even we do have a AFI committee in our corporation. So requesting you all to report all AFP cases below 15 years of age, fever with maculopapular rash, suspected diphtheria, suspected pertussis, suspected neonatal tetanus, and adverse event following immunization. Thank you, madam.
Thank you so much, Kishore. Can I make
Thank you, madam.
Yeah, is it okay to say something, Dr. Kishore?
Yes, madam. Yes, madam. Please.
Yeah, so a lot of centers where they give vaccination, they tell parents, they advise parents to apply ice as soon as they go home. So parents go home and start rubbing ice, and that causes a severe reaction. So that has to be discouraged. So we must tell them not to apply ice and not to rub that area, because that antigen gets spread, and it causes severe local reaction. Also, it may cause infection because there is an open puncture wound, and that ice may be unsterile. Dr. Kishore.
Yes, madam. Thank you, madam. That was very, very important point.
Another thing is that they give tablet crocin. Even a 1.5-month-old child, they give a tablet crocin, and they tell the parents, "Iska 4 bhag karo aur 1 bhag de do." So now that is a very incorrect way of giving a 1.5-month-old. So I think PCN drops are available, paracetamol drops. So parents should be every child who receives a vaccine should receive 1 bottle of paracetamol drops as well, and the correct dose told to them. So this was the second I thought which was important.
Yes, madam. And this guideline was given by the government of India also to use the paracetamol drop instead of the tablet.
But they're still giving tablets, sir.
But they're still giving a tablet. They are finding very difficult to implement it in the field. There are many reasons for that. Very small reasons are also there. Like, they feel that all the bottles are very heavy to carry in the field and all, this kind of reasons have come up. And they're being studied now. they are being studied, and some solutions will come out. Okay.
Yeah, because
Yeah.
then nobody gives, then there is a reaction. Third
Yes,
thing,
ma'am.
with the Muslim community, we are finding a lot of them are very resistant to giving any vaccine after the 9th month. So whether, we can invite some Shah Rukh Khan and so many Khans are there in the film industry, can do that campaigning for us that it is safe to give. So that, that community
Yeah.
we will be safer. That
Yeah.
was,
Generally, yeah. Generally, these kind of strategies are used for communication thing, generally UNICEF generally does all these things. So we will request them to do something
now
for our
this time
corporation.
Amitabh Bachchan will not work. Now we will have to take Shah Rukh Khan.
Yes, ma'am.
That was one thing. Then one more thing is that I
Yes.
about pertussis, we are seeing so many pertussoid coughs, but I don't think anyone nasopharyngeal swab has been taken. So whether we are doing nasopharyngeal swab for pertussis surveillance.
Yes, madam. Once the case is reported on this group, then we
Yes.
take two nasopharyngeal swab and a serum sample after 2 weeks. 2 weeks. We are doing it, but none of the cases got reported in our group yet. So I am requesting
Because we are
everybody
not-
to
so
report
we were not
pertussis.
aware.
Yes, madam.
Yeah, so we were not aware, but now we will start reporting pertussis cases, especially for all those on the Palghar group. Please do report any cough.
मैदाला दुकान घ्यायचंय ना तिथं ते चाललं होतं सारखं
Please mute.
बाबा नाही
Pallavi,
दुकान घ्यायचं
Pallavi, please mute everyone. Yeah. So that was one thing that we should be reporting. And thank you very much again, Dr. Kishore Chavan. You found time for us to give us this very important data. And
Yes.
we are still seeing lots of measles cases. And every day on the chat, there are at least 10 reports of measles
Yes.
diagnosis, not just fever with rash. So I hope this epidemic goes down very soon. And would Anuradha like to say something? Anuradha, any remarks?
Madam, I'm working in VVCMC hospital at Nalasopara West, but I'm not getting so many cases. Like I have seen 3 to 4 cases in last 2 months.
Yeah.
And mostly what you said, I have seen these cases in Muslim community.
Yeah.
Like 3 out of 4 were Muslim. So they don't want to give vaccine to the child.
Yeah.
So that we have to target that community.
Yes. And with that, we go on to Dr. Lalit Verma. Dr. Lalit Verma, are you on the... Hello, yeah. Hi, Lalit. Yeah. So, Lalit and Shruti, as you all know, Dr. Lalit Verma is a young, handsome pediatric gastroenterologist, very much into liver transplants. And today he has a very interesting, rare liver disease. So many new things that he has told us about, he's going to tell us about. And over to you, Lalit.
Thank you, Dr. Anjali. Thank you, Dr. Anuradha and Team IIP. And first, I'd like to wish everyone a happy Women's Day. And actually, it's actual Holi in North today. So happy Holi to everyone. So I have a very short, there's just 14 slides, but it's just a message that should go across to all our community. I'll begin with the case scenario. So we had this 9-year-old female who at present, this year she's 9. At 6 years of age, she developed bilateral swelling of the tendo-achilles region over next few years. So in the next couple of years, I would say between 6 and 8 years, she developed severe similar swelling in the bilateral knees, right ring finger, over the elbows and everywhere. So she was in a follow-up with an orthopedician that was suggested to her. Now, can anybody unmute and discuss what are we dealing with? Because it has to be 2 ways. If only present, that doesn't make sense. Anything that you can think of, bilateral tendo-achilles region swelling, what are we thinking of here?
Fibromyomas or fibromas.
Yeah. Anybody else?
Bleed, bilateral
Okay.
injury related, unlikely.
Okay. But yeah, there were multiple and actually it started growing. Yeah.
Acha, okay. So then
Okay.
calcifications in the muscle.
Yeah, perfect. So in 2022, family noticed increase in the size of swelling of all this, those swellings that were there. So this was related with breathlessness. There was a chest pain over last 2 years. ECG was done, which showed or was suggestive of ischemic changes. Angio was done, and she was advised, to visit a higher center. That's how she came to us. She was started on aspirin and Nicoran. Lipid profile was grossly deranged. TROP T was positive. Now, what are we dealing with here? In a young child, around 8 or 9 years, 8 years, kindly unmute and let's
Lipid
have a discussion.
related liver disorder.
Okay. Anybody have you come across any lipid issues in this young age? Anybody with a chest pain apart from your QT prolongation or anything other than like valve defect or anything else? A very well-grown child, and she was asymptomatic till the age of 6. So you said lipid disorder. Anybody else? Okay.
Familial hypertriglyceridemia.
My God, कौन है? Let me get the name. Okay, perfect. So, 2D echo was done, and of course, it's going to show normal size left ventricle with normal function. There was an MVP prolapse. It was mild aortic stenosis, and there was no thrombus. There was no effusion, the ASD, VSD, PDA, no co-ops. So everything was fine. So do you think this like a normal scenario considering the ischemic changes? I can see Sylvia and Manveen there. Kindly unmute if you are around. Dr. Anjali is also there.
Sylvia was there some time back. Sylvia,
Okay.
was there any valve motion abnormality? Because that would indicate infarction or something.
There's only this mitral valve prolapse, nothing else. I have more.
Hello?
Yes,
I'm there. Yes, ma'am.
Yeah.
Okay.
Can you hear me?
Yes,
Yeah,
yes,
very audible, loud and
Yes,
clear.
yes.
So,
Yeah,
Sylvia,
continue.
have you come across such scenarios like ischemic changes, 9-year-old, and
No, sir.
no prior?
No, sir. I've seen one case which had a coronary aneurysm following Kawasaki disease. Kawasaki disease was not diagnosed. Was sent to Ambani very later with huge aneurysms, and that child had this infarcts. And then that time I've seen a CABG in around 10 or 11. I'm not very sure, but around 10 or 11-year-old that child was.
So this is
that
post
is
sequelae of
Kawasaki.
Kawasaki.
Yes.
No, Sylvia, we were wondering with an ECG which was abnormal, how come the heart is normal? So what else we should also, I thought we should have looked for wall motion abnormality to see for, myocardial infarction or something.
Yes, ma'am. Regional wall motion abnormalities we can suggest, or even the myocardial vasculature, the echo texture of the myocardium is a little different. You can see some hyperechogenic myocardium in such cases, or something like that.
Right.
But there was none over here.
Okay. So the next was, of course, this was in the interior Maharashtra. So then they came to Mumbai, and this was the CT angio findings. So diffused, hypoenhancement along the septum. There was supravalvular aortic stenosis. There was stenosis. LED was, 90% tight. There was an osteal lesion in RCA. So ultimately, the diagnosis was acute coronary syndrome with 3 critical vessel disease. That fits in. So the previous 2D echo was done in a very interior place in interior Maharashtra. So of course, that will not correlate with this one, the findings that we see. So again, whole genome sequencing was done. Anybody wants to have a say what this could be?
Shruti,
The CABG was...
only the ladies here can answer.
Huh?
So I think whole exome
It's
is
a
what you
women's-
mean.
Today's Women's Day, so only women can answer this.
Okay.
Others
Yes,
as
you
well.
muted all the guys. Okay, fine. Okay.
Yeah.
Yeah, Shruti, I'll get you in just one more. So she was continuing. So the CABG was done actually in April. So of course there was a delay. These things were picked up actually in February. The family was not very convinced. They came back in March, and then again the CABG actually bypass was done actually in April. So in the interim period, she was started on aspirin, Nicoran, and then again Atorva and ezetimibe was added. Now, Shruti, this is for you. If you want to, this is the slide that we need to discuss. So this is her genome, which came positive. Shruti, please.
Yeah. No. So just one small edit. This is the whole exome sequencing. Whole genome is a different test. But yeah, having said that, as compared to the previous report where we saw Dr. Vaishali's case presentation, it was an uncertain finding on the rightmost column. You can see here in the rightmost column, these are both pathogenic variants. So here the evidence of causality is very high. It is a LDLR mutation, two mutations. We call it as compound heterozygous. And rightly so, as suggested by someone in the audience, this was a familial dyslipidemia following an autosomal recessive trait. If you can see, there is a lower half which has two uncertain findings. So this is it. These were not causative. Everything that comes on the report, even though the lower two variants are associated with dyslipidemia, after a lot of further testings, going backward and looking back at things, those two were discarded out of the picture. So that's it, Dr. Lalit. Yeah, I mean, and the autosomal recessive explains why. I think you're going to come to that. Yeah, there were two.
So this was definitely compound heterozygous. And then, of course, the counseling started because, the mutation actually, although it's related to the heart ones. Although the findings are more or less associated with the heart, but the mutation actually, the gene actually, or the carrier is in the liver. So it's all related to the liver. And we had to offer her liver transplant to save her life. CABG was something to save the heart, but then there can be such similar, kind of ischemic changes elsewhere. It can be a gut, it can be the brain, it can be anywhere else. So this was her initial lab. So actually she got transplanted here in December. So these are her pre-op lab. Of course, everything AST, ALT, bilirubin exactly are going to be normal. INR was slightly deranged. This was her thyroid profile, which was completely normal. And, prior to her transplant in November last year, look at the cholesterols, more than 530. The HDL were 28 to 39, but look at the LDL also, 469, and triglycerides were 510. So Shipal actually, did the 2D echo in his setting. So not very clear, but I'll just try and, yeah, okay. So now you see there's a trivial aortic rigor. The aortic root is hyperechoic. There is significant narrowing of the aortic root, and there's no significant supravalve stenosis. So this is the post CABG. Just before the transplant, we like to get cardiology clearance as well for all our patients. So there was no abnormal Q wave or ST changes, is what he has mentioned.
Was this child on statins pre?
Yeah, the child was on statins. So we did the transplant, and of course the father, came forward. This is the father, and actually this is the girl Avni. So father gave it to the daughter. The sad thing is there's another sibling who's 7 years now. He has started to get similar changes. So we are going to take him next month. Again, mother is the donor for the son. So both the siblings have this genetic mutation. It's compound heterozygous in both of them. And this is the father here. And you see this changes here. So total cholesterol, which was 530 or 500, has come down to 230. I do have the recent one again. It is somewhere around 200. The LDL, which was in 460s, has come down to 175. Now, having said that, they do not completely get into the very normal range. Sometimes, they can just, there's a point they'll reach and they'll just settle down there. But it is not something like beyond 250 or 300 based on the studies. So they do, there is a positive outcome and they should be offered a transplant if you're dealing with this compound heterozygous mutation. And I'll just bring you.
Lalit is eating so much cream.
No, that was a birthday. It's only a bite.
Okay.
Yeah. Then we have a dietitian following her. We only allow during the post-op.
My mouth started watering. Yeah.
So, this is almost like a similar scenario, but this is homozygous familial hypercholesteremia. We had the one that we had is compound heterozygous. And again, here, there were two siblings. This is from Japan. And again, here, since there is a shortage of deceased donors, cadaveric donors in Japan, Again, if you see the combination of living donor liver transplant from a heterozygous donor was offered, and again the donors have been parents only. For this kind of patients, it's difficult to list them in the cadaver list because they actually do not reflect a liver problem. So it becomes difficult for us, based on our criteria, to offer them an organ if they come, because this is mostly curative for the heart and for the other dyslipidemia. So even if you put them in the cadaver, they very minimal chances that they'll get it. So again, the girl is doing fine. They are back into their hometown. We are trying to get the brother who actually has similar problem and actually started to have some chest pain. So I've called them. We'll have a cardiac evaluation here, and then we'll not wait. Like she underwent a CABG, so we do not want to delay, and we'll be doing this child actually on 29th of this month. Thank you.
Thank you so much, Lalit, for this wonderful presentation. So unusual to see. Of course, you have put up your hand, Shruti.
Ma'am, can I ask a question?
Can I make? Oh, I'm so sorry. I'm so sorry. Please go ahead. Yeah.
I wanted to know what were the swellings in the fingers and the both the calves bilateral.
Yeah, so some of them are xanthelasmas, xanthomas.
To such an extent that they were bilateral at the same time. They were, I mean,
yes,
little,
yes. And one of them actually is huge. It's like probably she'll need a plastic surgery. It's right there sitting in the tendon, Achilles tendon. And so we told them that, we'll wait. Not necessarily all of them will decrease in size or subside. Discussing with my other colleagues also, but then, of course, there might be a regression. And if there is a kind of problem in future, then we'll probably have to excise it and get it out. But, so far, so good. She hasn't complained. It's been like what? We did it on 29th December,
3
and
months.
we are into almost 3 months.
Almost,
so no chest
2.5
pain.
months.
Some of the xanthelasmas actually have started to disappear. I wouldn't say like, maybe by 60% are still there, but still it's a positive, kind of feedback for us, because even we were apprehensive to do, such kind of surgeries. But, we checked with our international colleagues, and then we offered them along with Shruti and other my surgeon colleagues. So probably they'll be talking about a couple of cases. So we are very happy that this has come out very positive.
Okay, she had facial manifestations also, like xanthelasma.
Yes,
like
xanthelasmas were all here. Yes, so they
Okay.
actually, the eyelid ones are actually completely disappeared. So the face wise, she looks ekdam proper.
Post-transplant. Okay.
Yes, post-transplant.
Lovely.
The ones on the extremities and all, they're still there.
Okay, thank you.
Thanks.
Yeah, Shruti.
Ma'am, just one comment. So what Dr. Lalit rightly outlined, that in this case, it was heterozygous parents. Now, this is when in genetic disorders requiring renal, bone, or liver transplant, genetic help is sorted, because sometimes taking a graft from an affected parent in some diseases can be detrimental. And I remember having this brainstorming session with Dr. Lalit that ideally in such a case, because it's an affected parent carrying a dominant mutation, they are not the best candidates. But in the absence of a cadaveric donor or an unaffected family member, live donor, the third best option then falls down to a affected, someone like carrying a heterozygous variant from the family itself, like the parents were willing. So that is just a word of clinical significance, that in a lot of these disorders, many a times transplants are conducted, but kind of joining the dots, taking the parents on the same platform, they understand that the outcome may be guarded in such cases. That is little important, madam. That was my only thing which I wanted to add.
Thank you so much. And if Dr. Lalit had shown us some clinical pictures of the xanthelasma.
I have the pictures. I will share it on the Palghar group.
Done.
I just want to ask one thing.
Yeah.
I just want to ask one thing, like since it is a genetic disorder and one of the parent must be suffering from the same disease.
Both.
So are both the parents allowed to give their
That's
liver
what
to
she
the
explained
child? Is
just
it
now.
possible?
Yes, Lalit, you want to take that on?
I think muted, yeah.
Yeah, ma'am. So ideally, that is what we told, that they are not ideal candidates to be giving the liver in such a case. But Then they found literature and positive experience from few case anecdotal reports in Japan. And after explaining to the patients that there may be pitfalls, you can go ahead in such a case.
Okay.
So yeah, as she said, so we had a lot of counseling session. We told them, we tried to get in maternal uncles, paternal uncles, but nobody came forward. And especially we were dealing with both the siblings. We had to take the call. We checked our, we did a PubMed search and we looked into articles, spoke to our colleagues. And once we were very sure and affirmative, then we said, okay, fine, we can go ahead and get this done. And then again, I told the parents that do not rush in for the other sibling. Let's see what the results are in your older sibling Avni, like this girl. So once they are very sure, and now they are pushing, because I told them at least give me 6 months ka time between the two kids so that I am very sure on my part. But now they see that positive outcome, so they want to push in. So again, I've told them not before 3 months.
Okay.
Yeah. So you have pictures of the tendoachilles xanthelismas?
I'll share with you. I'll share with you.
Yeah.
Shruti, if you have, you can put it in the group as well. Sure.
There is some corneal ring also because of the lipids.
No, that
Sorry?
is acephalus.
There is one corneal ring also which is present in this people who have got hypercholesterolemia.
Corneal ring.
Yeah, corneal ring is there. Yeah. And they said that they are like more common in some communities, like in Jews, or like they have some prevalence.
I'll get the ophthal done at least for the younger sibling that we are going to evaluate now. So they are coming next week. I'll make sure that we get the ophthal check done at least for him.
Okay.
Sure. Good input. Thank you.
Yeah, when I was doing my medical post, that was decades ago. And while on the round, Dr. Farooq Utwadia was our unit head. And one young girl who was with her brother, she had xanthelismas over her eyelids. And Dr. Udwadia asked our registrar to get the cholesterol done of them. And that patient turned out to have hypercholesterolemia and was familial hypercholesterolemia. So I know about these xanthelismas, but this is the first time I'm hearing about tendoachilles xanthelismas. And so that's very interesting. So please do show us these rare signs.
Sure, I will.
For life. Thank you so much. And with that, we'd like Dr. Rajiv Sinha, but I can't see him here.
Rajiv, are you there? Kindly unmute. I just called him because, there's a transplant going on. So Gaurav and Rajiv are both inside. But then I called my anesthetist friend to get one of them out for this presentation. Rajiv, are you there?
Or you will have to make the presentation if you can.
Actually, he's not shared it. One second.
So we next have a very, very interesting case. We've heard of liver transplant now, and we've heard of kidney transplant so many times. And we've even heard of a heart transplant and a corridor, which happens even in India with a heart from one city to another. But we've never heard of an intestinal transplant, and that's what we're going to hear about today from Dr. Rajiv Sinha. And Dr. Barot is looking very, intellectual, and he's going to share something with us. And he's going to wish all ladies a very happy Women's Day. Are unmute to karo.
आता किती दिवसांनी झूम वापरतो तर मी विसरून गेलो कसं वापरायचं.
तेच म्हणून आम्ही म्हणतो मीटिंगला येत जा.
Happy Women's Day, ma'am. All of you.
All of us, yeah. So happy to say that there are so many ladies in our team. We have our senior ex-president, Dr. Archana Joshi. She's busy elsewhere on Women's Day. We have Anjali Kokan as our president. We have Dr. Vaibhavi Barot as our secretary, Anuradha Palmankar as our treasurer, Dr. Jayashree Deshpande as our vice president. And the only fellow who is there in this entire team is Dr. Shailesh Barot. And he got to wish us. Now, how can that be? But it's okay.
That is why I put up the photo on the PPT, ma'am.
Okay. So we forgive him because he might get overwhelmed by all us ladies. But there
Always.
is Rajiv Sinha.
Rajiv, are you there?
Lalit, if
he's
you
there.
have he's there.
Yeah, he's there. This one.
Yeah.
So Rajiv actually is going to present. So intestinal transplant actually is a topic for Gaurav Chaubal. I'll just call him. So Rajiv is going to talk about the other case. Photo. What? Okay, so you're given it, Abernathy. I wanted them to just. Okay, fine. So Rajiv, if you're there, kindly.
Where's my?
Welcoming Dr. Rajiv Sinha. Dr. Rajiv, can you please give your introduction, because
Yes, I will. First of all, good afternoon, everyone, and I hope I am on time. We are just finishing up a transplant, so sorry for the delay. I am Dr. Rajiv. I've done my MBBS from JJ and MS from Pune, then my transplant fellowship from Philadelphia, US. I practice in a lot of hospital currently at Global, doing our liver, intestine, and pancreas transplant along with HPB surgery. That is about me.
thank you so much, Rajiv, and welcome to our forum. And I'm sure we would like to have you very often. And today you're presenting on?
I'll talk about Abernathy, one of interesting cases which we encountered recently.
Yeah, please go ahead.
How do I share my screen?
Pallavi, त्यांना share screen allow करा.
Ma'am, allowed है.
Dr. Rajiv, you can share.
Yes. Okay, let me just find.
In the panel below, you'll see a green button.
Just click on the share screen button, sir. You will get the window which you want to share.
Just give me a minute.
Yeah, sir. Just first open your presentation, make it minimize, and then click on the share screen button.
Okay, first I'll have to open my presentation.
Correct, sir. Just open your presentation first.
Okay.
Make the window minimize, and then come to the zoom window. Is it coming, sir?
Yes, I minimized it, and then
come to your zoom window. You'll get the button of share screen.
I got that share screen.
Click on that.
I clicked it.
Yeah, you will get multiple windows.
Correct.
In the thumbnail, click on the window where your presentation is there.
The desktop, or like wait.
No, not the desktop. You must have get the thumbnail of your presentation in that windows.
1 minute.
Rajiv, can you send it to me? I'll just upload it from my end.
Yeah, can you do that?
Yeah. Just send me on email. Let's do it now. In the meantime, Sylvia, are you there?
Oh.
Sylvia, का काम वापस आ गया है.
हाँ, Sylvia is there. Sylvia, please unmute. Yeah. Sylvia is there.
So yeah, we have shared patients, Sylvia, me, and Prashant, and of course Shreepal. So even Prashant has a good number of Abernathy syndromes patients. Now, not everybody is going to benefit. I mean, will require a surgery or benefit. That of course Raju is going to talk about. Raju, मुझे भेज दिया presentation.
No, I'm just doing it.
Lalit sir.
Yeah.
Since you have worked with Prashant sir, you must be knowing about his case series about Abernathy
Yeah.
malformation. Yeah.
Recently, he's not shared any details because we haven't met, but yes.
Yeah.
So, but I
Yeah.
think the case series is quite huge as far as I know.
Yes,
Prashant,
it's a huge case series, and I had presented a total of 8 cases in a pulmonary hypertension World Congress in Miami in 2016.
Okay.
When I was working. After that, also he has had a lot of patients, and a lot of device closures have been done.
Okay.
Amazing.
Dr. Hemant Joshi का भी एक है ना? In the meantime, if he is ready.
Yours is Lalit Verma, that na?
Dr. Verma Lalit at gmail.com.
Okay, I've sent you.
Events that are actually happening for women today, Women's Day, and Dr. Archana Joshi, Hemant Joshi are caught up with Virar Medical Association. I think Dr. Shri Deshpande was caught up with Nalasopara Medical Association. And I'm happy that Vaibhavi and Anuradha and Shailesha plan to stay on. Because with everyone running behind women, who would be here at our forum? So we are extremely happy and proud that Sylvia has presented such a big series of Abernathy's at Cincinnati, you said. So that's great. We are so lucky to have Dr. Rajiv Sinha. In fact, we have almost pulled him out of the OT when he was doing such an important thing like a liver transplant. So, and he also said something like we do PPS transplant. Now, what is that? So perhaps sometime during his talk, he's going to talk about that.
So how big was the Abernathy presentation at Cincinnati? Like how many cases?
Sylvia?
Hello?
Yeah. Dr.
Yeah,
Rajiv,
yes, sir.
I was just going through some literature search about Abernathy because we just
presented a case series about 6 cases, all seen at Kokilaben Ambani Hospital. Age group varying between 3 months to I think 17, 18 years. I don't remember, that was like years back. And we had done successfully device closed 2 of them at that stage. A few were on follow-up.
Oh, wonderful.
And one case in specific which I remember is this lady was diagnosed to have pulmonary hypertension, was being treated outside as idiopathic. She came to us at 5 months of pregnancy. Pregnancy was managed in Ambani with like it was a task managing her pregnancy and postpartum period. And later when we investigated, we found that she was a case of Abernathy malformation, and then she be device closed, and then her BA pressure has normalized.
Yeah, Dr. Rajiv, your presentation is on, so you can start.
All right. So first of all, thank you to all the organizers for giving this opportunity. I'll be just presenting a case of interesting case of portopulmonary hypertension. So the mother was a 28-year-old G3P2A2. Third conception was by IVF. And at 18-week, the NC scan had suggested some fetal tachycardia and echogenic foci in the liver and heart. Again, the 28-week NC scan had the left portal vein and the umbilical vein connection was not seen. The portal venous circulation was very rudimentary, and the RA and RV was dilated. Yeah, so coming to the birth history, a full-term female child was born through a cesarean with a birth weight of 2.8 kilos. There was no, she had an extended 1 week of NICU stay in view of the physiological jaundice. 2D echo suggestive of small PDA, which was managed conservatively. She was growing well with no significant complaints during the first year of life. And then during the second year of life, she started developing progressive dyspnea. On further investigating, she was found to have a congenital extrahepatic portosystemic shunt. We move forward. My slides are stuck. Yeah, wait.
You want another slide or this one?
Can I go back to the previous slide to see whether I have skipped any or not?
No, this is the third one.
Yeah, so at the age of 2 years, I think here in Bombay, a transcatheter closure of portal vein to the IVC shunt was attempted. Multiple angiograms done during the procedure demonstrated a side-to-side channel between the common portal vein, the main portal vein, and the IVC. And there was just aneurysmal dilatation in the distal part of the portal vein without any left or right portal vein seen. They tried to block it with an occlusive device, but as you can see from the it was unsuccessful, and it led to complete occlusion of the portal vein. There was no forward flow inside the liver, and there was stagnation and immediate there was no flow in the portal vein. So they abandoned the procedure and they were advised surgical closure. They again went to see AIG after 6 months, where they again tried to do the shunt closure. But again, it was not feasible in view of the increased portal pressures. As you see, before the occlusive device, the portal pressures were 6 and 4 mm of Hg. And the last line you can see. And then post balloon occlusion, it almost went up to 22, which would not have been tolerated by the child. So she was started on medical management with endothelin receptor antagonist and the phosphodiesterase inhibitors. Thereafter, she was lost to follow up, and she was non-compliant with the medications. She started complementary alternative medicines. And then later on, she presented to us at the age of 7 years. She was able to do the normal activities of daily living, but was not able to run or do strenuous activities. Her saturations on room air was still more than 95%. Next, if you can help me with the, yeah. So there's just the scan. I'll just, can you just play it for me? I don't know why my thing is not working.
Yeah, even from my end, it's getting stuck. Yeah, one second. Yeah.
It's okay if it is not getting played.
Yeah. No, it's not. No, one second. One second. Yeah, it's playing.
Yes.
Yeah. So if you can see, there's no left and right portal vein you see, and then directly you see the main portal vein. And then as you go further back, you can see it draining into the cava. Similarly, if you can play
no,
the
we could not appreciate it if you can play it again.
Sure. Yeah. I get a control. So there should right and left should come here, but directly the main is coming. Can you stop Lalit here? Or just
1 second.
Okay.
Stop where? But just tell me. Okay.
I'll tell you. Yeah, stop.
Yeah.
Just a little back.
This one here?
Yeah, a little back. Yeah. So there should be a right and a left portal vein joining to form the main, and then this would be further if you go down the splenic. So there's no right and left, and the huge aneurysmal dilated distal part of the main portal vein. If you can continue it further. And this is going directly into the cava. This is the lower portion being formed by the splenic, and I'll show you better in the coronal. If you can see the coronal.
Next one.
Yeah.
1 second. You can share the images also with all those proper cuts actually, Raji. See here.
Yeah. So if you stop it here, yeah. stop it. So can we stop?
1 second, I'll take it behind. Yeah. Here.
Yeah. So, so this is the portal vein getting formed, the splenic and the SMV, and it should then further bifurcate into the right and the left. But it's just the distal portion of the portal vein. You see a bulbous dilatation of the portal vein. And then as we move further, it's a coronal cut. So we are moving backward towards the spine. So as we move backward, you can see the cava, and this is the shunt which is entering the cava. I think if you can appreciate that. And this is the cava. This is the cava. Yeah, and this is the shunt. This is the shunt just going into directly into the cava. Yeah. So coming to the management, there were three limbs to the managing such a patient. Firstly, she has been for 9 years, 7 years with severe pulmonary hypertension. So we needed to assess the severity of the pulmonary artery hypertension and to see if we can medically optimize her enough so that we can offer her something. Second would be to do a liver biopsy and confirm the presence of portal venues in the portal tract. Also to assess the stage of the liver disease, and only if we can even see some portal venules in the portal tract, then we can attempt a stage closure. And if both two criteria are fulfilled, then we intended to offer her a 2-stage shunt closure procedure. So this is the liver biopsy.
Pallavi? Sorry, Rajiv. Pallavi, can you mute everyone? Yeah, Rajiv, go ahead.
Yeah, so this is the liver biopsy which we did. We did show that there were portal vein radicals seen in about 60% of the portal tracts. Obviously the portal tracts were the portal venules were atretic, so the portal arterioles were prominent and increased in number and size. And the liver didn't show any significant fibrosis. Next. Yeah, and then the important aspect of this case was mostly how to optimize the pulmonary artery hypertension. The initial presentation, the 2D echo showed severe pulmonary artery hypertension, moderate TR, dilated RA-RV, although normal biventricular function. The estimated mean and diastolic PA pressures were supranormal. I mean, 54 plus right atrial pressure and a 30 of right atrial pressure. Generally, even when we do transplants, any mean of more than 45 is generally considered a contraindication with very high mortality. We would like ideal mean would be less than 25. Between 25 to 35 is something like a mild pulmonary artery hypertension. 35 to 45 is moderate, and anything more than a mean of 45 millimeters of mercury, those candidates are even refused transplant. Anyway, she was started on sildenafil and ambrisentan. 2 months later, again, 2D echo was done, which didn't show much improvement in the mean and the diastolic pressures. Just a marginal, it fell down to around 46. But at that time, we had a multidisciplinary meeting and our anesthetists. They used to handling these kind of pressures. So we had a good plan how to take her intraoperatively through the surgery. And we posted her for the surgery. I mean, she went the first stage of the stage procedure on 24th August. And the shunt diameter was almost 12 to 14 mm. The liver was soft. We did occlude 50% of the shunt with medium clips and observed her for at least half an hour to 45 minutes to look for if there is any bowel congestion and edema. We also called intraoperative Doppler to see whether there is any flow which could be seen after occluding the shunt in the left or the right portal vein. We could see some, although it was not significant. And then we measured the pressure in the omental vessels also, so that she suddenly doesn't have too much of portal hypertension, and the pressures came around 14 millimeters of mercury, which was acceptable. I was even tempted to see if we can occlude it fully in one step and just get away with it. But the moment I occluded the entire shunt, you could see the flow got so sluggish in the portal vein that it almost started clotting off. So we immediately removed it, and we could just achieve a 50% closure. Yeah, next.
Yeah, so Dr. Rajiv, where did you transplant that portal vein into then after that?
No, so I've just, if you see the picture, below the clamp is the cava, and the liver is on top, and the portal vein is going directly into the cava. And there is like 50% of the shunt. I have put a clamp on the shunt, the porto caval shunt. And then after this, we measured the pressure in the mental vessels, the flow in the intraoperative Doppler. And if you can see, the liver looks quite soft, and it's still not fibrotic or gone to a stage. So this is, and once we knew that after occluding 50%, the patient is tolerating, then we just applied clips and completed the first part of this procedure. She developed severe pulmonary artery hypertension post-operatively. I mean, if you can see, post-op day 1, her estimated right ventricular systolic pressure was 100. And in the second one, you see it went up to 140, which was supra-systemic range. It was more than the systemic pressure. We had a good ICU cover. We started IV sildenafil infusion. Luckily, it all responded. And then by day 4, her pressures were back to the baseline. She was tolerating only, her drains were out. PA pressures and IV sildenafil was changed to oral, shifted out of the ICU on day 4, and the discharge around 7. At discharge, the PA pressures were again back to those 55, 50 range. And then we did plan a second surgery probably after 2 to 3 months. Follow-up, we did a Doppler at 1 month. The right portal vein was still attenuated, but the left portal vein trunk did show some patent intrahepatic branches. Probably with the pressure, they were opening up the atretic portal veins, venules. And 2 months later, or probably 4 months later in December, we did do an echo. The pressures were almost the same. The mean was 45 with so we then planned the second stage of the shunt closure. She underwent the second stage surgery just last month on 18th of Feb. And the post-op course was similar to the first surgery, largely uneventful, and she was discharged on POD6. So just coming to a little bit about the discussion, what I've just went through some literature yesterday. So Abhinati, as we all know, is a congenital abscess of the portal vein, also known as congenital extrahepatic portosystemic shunt, or CEPS, first described by John Abernathy in 1793 in London, England, while doing a post-mortem on a 10-month-old girl. If you can see the picture, this is the original picture which he has published. And there were many congenital anomalies found, such as dextrocardia. The great vessels were positioned polysplenia, and the portal vein bypassing the liver and terminating into the IVC at the renal vein level. Anatomically, it's divided basically into type 1 and type 2. Type 1 is the complete end to side shunting, where the entire portal circulation is being shunted into the cava. And type 2 is a side to side shunt, where a part of the flow is going into the cava and a part is going into the portal vein, although it's atretic, but it's not a complete shunting. And type 1 is further divided depending on whether the splenic and SMV is joining and then forming a common trunk, or they are draining separately into the cava. So if it is draining separately into the cava, we call it type 1A. If it is forming a common trunk and draining into the cava, then it is a type 1B. So a lot of times literature, say that, generally, if you look at it, a type 1 should not go beyond a certain age. People who present in adulthood, I believe probably they must have some type of type 2 to keep that we'll discuss later. So this is a very extensive, this is an article which I found in Hepatology in 2019, where it's a multi-center observational retrospective international study for probably defining the largest cohort of abernathies found across the world. There were 23 participating hospitals. And most of because abernathies are case reports, there's no consensus guidelines or anything how to manage them. So this study tried to describe the clinical manifestations, the natural history, current diagnostic procedures, treatments applied, and the outcome of large cohort of patients with SEPs, with the aim of proposing a homogeneous guidelines. I'll just 2-3 slides. I'll go through the key points what they have mentioned in this. In countries routinely performing neonatal screening for hereditary galactosemia, the estimated instance they have estimated around 1 in 30,000, because the galactose is not getting through the liver, and that is why they have high levels. But then again, sometimes even in Abernathy, you don't see a very high level. So maybe the instance would be a little higher than 1 in 30,000. In the literature, they came across around 300 cases of SEPs being reported, although they only found 66 cases eligible to be included in this study. And the spectrum of variants range from completely asymptomatic forms to severe forms of hepatic encephalopathy, hepatopulmonary syndrome, and pulmonary artery hypertension. Nodular lesions are also very frequent. Most of them are benign, although SCCs and adenomas have been reported. So all the patients were incidentally diagnosed through imaging tests. In 20%, the imaging test was performed because they had already some symptoms which could be potentially attributed to SEPs, like HE in 6 cases, dyspnea in 7. And in the remaining 80%, the imaging study was performed for some other reason, and they diagnosed the SEPs. And the median age of diagnosis was around 21 years. The 3 main complications of SEPs. One is the hepatic encephalopathy, which is seen in around 30%. And the median age of HE was around 12 years. Second common is the liver nodules. They found liver nodules in almost 65% of the patients. Out of them, 18 had neoplastic lesions, 8 SCC and adenomas, and 25 patients had non-neoplastic lesions. So this nodules would be the commonest complication in congenital extrahepatic portosystemic shunts patients. And then the third are respiratory complaints relating to the pulmonary vasculature. They can either have a pulmonary artery hypertension or a hepatopulmonary syndrome. Basic difference in a hypertension would be the vasoactive amines are bypassing and making the pulmonary vasculature very vasoactive and ultimately leading to severe pulmonary hypertension. Whereas in HPS, it is more the dilatation and causing a perfusion mismatch, leading to severe hypoxemia. So 10 patients, these are the cumulative incidents which they have shown that as the age increases, the incidence of complications increase. Next. So just 3 slides on the HE. HE can be improved with lactulose and rifaximin. Patients with persistent HE, 4 out of them underwent shunt closure, resulting in cognitive improvement and decrease in ammonia level. And 2 patients even had liver transplant. One presented with SCC and the other with concomitant, adenoma and HE. So they were transplanted. Next. Next one. For the management of pulmonary artery hypertension, which our patient had, an HPS, they had 7 out of 10 remained stable, the disease with specific medical management. And they had a long follow-up of 7.5 years. 3 patients did underwent shunt closure, observing a clear clinical improvement. Out of the 3, the clinical improvement was seen only in 2. And they said the basic of improvement and whether the patients will improve or not will depend on how young the patient is, how low the mean pressures are, that means how permanent the vasculature has already become, and how much is the duration of the total hypertension from the diagnosis. Our patient probably was young, had a relatively around 50 of a mean and a shorter duration. So hopefully long term, we don't know, but we'll know whether she's really improved or not. And 2 patients underwent shunt closure for an HPS, both at the age of 41, and both have had resolution of their hypoxemias. For the liver nodules, in their study, they had 8 patients with SCC. 1 presented with acute hemoperitoneum who died. 6 patients, 6 underwent surgical hepatectomy. 3 showed no recurrence after 3 years, whereas 3 showed recurrence after around 3.5 years. And 1 patient who had concomitant HE underwent liver transplant and is doing well so far. Out of the 10 patients with adenomas, 3 were treated with surgeries and 5 were transplanted. 1 underwent shunt closure. And in 5 asymptomatic patients with liver nodule, shunt closure was performed as a preemptive measure, and probably all of them showed a regression in the size of the nodules. Overall, just to summarize, what they found was in their case series, 15 patients underwent shunt closure. A chronic HE was the indication in 4, pulmonary hypertension in 3, HPS in 2, adenoma in 1, and preemptive in 5. The median age of shunt closure was around 17.5, ranging from 3 years to 41. Surgical ligation was done in 11 and a percutaneous endovascular technique in the remaining 4. The election of surgical versus endovascular was guided mainly by the size of the shunt. And in 6 patients, the procedure was done in 2 steps to facilitate progressive reduction in the portal blood flow to the liver. Just last 2 slides. This is another article which I found quite interesting. There have been 34 liver transplantations performed worldwide for congenital absence of portal vein. The indications are HPS in 13 cases, respiration complications in 11, liver mass in 5, and 4 had associated biliary atresia and 1 had persistent rectal bleeding. The grafts were mostly from brain dead donors and 19 living donors. So this is the point I was trying to make. Like a liver transplant probably would be the choice in a type 1 Avarnati, where you don't have any, and they probably are the patients who won't go on to live on long. If someone has lived long, like 7-8 years, I'm sure there is a component of type 2 in it, and for them it would be better to go for a shunt closure. Either percutaneous would be the first choice, and if not, then if you cannot do it in 1 step, then a surgical closure or a 2-step surgery can be offered. Thank you.
Amazing, Dr. Rajiv, and I'm sure I haven't understood more than half of what you have said. All I know is that now there is something called an Abernathy syndrome, which we will have to keep a watch out for. My question was, this child was detected even antenatally with some echogenic problems in the portal vein. So could a preemptive, investigation and management be done even then?
Preemptive, I am not sure whether management could be done, but yeah, at least if you know what the problem is, we can not let the disease progress to a point where she might require a lung transplant in the future. Her pulmonary pressures are so high, she might have a heart failure. So at least that can be tackled at a earlier stage and not let
Yeah, so in your patient, you just in the first stage, you did a clamping of 50% of the shunt. And then later on, you clamped the whole thing. And what did you do with that part of
So
the
No, so the blood is getting directed from the portal vein directly into the cava. So you do a graded clamping and allow that with the increased pressure, the arteritic portal veins open up. The idea is to have a graded closure, and with the pressure, just because there are portal tracts there on the valve, see, it is just atresia is there. So you just increase the pressure gradually so that they open up and eventually
they start working.
They start working.
Okay. Fine. Amazing. Thank you so
Thank
much,
you.
Rajiv. And there's so much to pediatric gastroenterology. And what we are right now managing is just the tip of the iceberg. And there's so much depth to all that. So thank you, Dr. Lalit, for introducing us to Dr. Rajiv Sinha and for this wonderful Abernathy, very, very rare case. And actually, you all are talking of a series of cases and things like that. And this is the first time we have heard of it. So,
So just to add, Abernathy's are actually picked up by the cardiologist, and they are the ones who tell us, okay, there's a pulmonary hypertension already there, and then probably it is not directly the heart issue. It is more like a, type 1A, type 1B, or type 2. So they are the ones, and luckily we have some very good cardiologists, who have seen such kind of cases, so they can easily pick up.
Amazing. So, yeah.
I just spoke to Gaurav, actually Rajiv and Gaurav, they are doing a robotic surgery, transplant only. So I think Rajiv, can you update? I think he's doing the artery. So the anesthetist told me that he can't come out right now. For
Yeah,
his, he was going to present intestinal transplant in a pediatric patient. Yeah, Rajiv.
I mean, I can just, I think it will take some other half an hour, 45 minutes for him to go free. So I can just briefly just talk a little bit about intestine, introduce it, so that at least we'll know that how it is done basically.
Yes, I think that will be really appreciated because even that's something so rare, we haven't even heard of it.
Correct.
Heart transplant, maybe we've even heard of a brain transplant, but never heard of an intestine transplant. So please do tell us about it.
So, I mean, I don't have the slides, so I'll just talk, and any question we can make it more like an informal discussion.
Yes.
So most of the times the intestinal failure is seen in adults when you have a complete SMA thrombosis, either because of they have a thrombophilic syndrome or protein C, protein S or something. So acute mesenteric ischemia, and where we see that they undergo emergency laparotomy and the entire bowel from the jejunum to the mid of colon, the entire SMA artery is necrosed, end up having a massive bowel resection. Only a 10 centimeter of jejunum is left, and the distal portion of the transverse colon and the descending and sigmoid is left. So these patients ultimately are doomed. They don't, they will over the next few months be malnourished, and eventually they lose their lives. Because in India, we don't have facilities for TPN. They are quite expensive. They need a very good line management. They need PICC lines and a very good catheter nurses who can manage. In US and Europe, we have patients on the waiting list who have been on TPN for 2 years, 3 years, and they're doing well. They even gain the weight. But in our scenario, so that is the commonest indication in adult undergoing acute mesenteric ischemia and massive bowel resection. Others would be a dysmotility, a malabsorption syndrome kind of thing, where the bowels are not working and there's no absorption, and sometimes you do have mega intestines, mega colons, and it's just not functioning. So that is another one. And neonates and pediatric gastritis and all these necrotizing enterocolitis would be the other main indication where we see pediatric population being referred for a intestine transplant. And as I already told you about the dysmotility disorders, something like a small intestine Hirschsprung or something where it's just not functioning. So these would be roughly the common indications for people who might need intestinal transplant. Even initially, we try to maintain them on a TPN, but the final cure would be to provide them with a transplant. Generally, across the world, the majority, 95-99% of the transplants are done from cadaver, because to take an intestine from the living is another big challenge, because no one is used to it. Even in European and American centers, they have so much of cadaver that they hardly ever try. So we were also initially doing a lot of cadaver related intestinal transplants for these kind of. In the COVID time, we had to do our first living related intestine, because obviously the 2 years in COVID, there was no donor. A small boy had come to us, very sweet 6, 7, 8-year boy, and who needed a transplant. And we then told, asked the father, and he was ready to donate. It's not there in the literature too much, so we had to read a lot, find out how it is done, talk to a lot of experts from around the world who had little experience. So basically, for a donor can donate up to 40% of their intestine safely without they developing any malabsorption syndrome. And because this was a kid, so he needed much less, like 100 or 150 centimeter of intestine. And normally our intestine is in the range of 700-800 centimeters. So we would be taking just 20 centimeter of the intestine. We leave the terminal portion of the, we leave terminal 20 centimeter of the intestine behind, so that the donor doesn't suffer from the
B12
yes. And then we measure the intestine, and along with the vascular arcade, the artery and the vein, we dissect it meticulously, and we take it and then we implant it directly, because most of the time the SMA and SMB is thrombosed, so you directly implant it on the cava. So you do a systemic, and then after you reperfuse the intestine, then you join the intestinal ends. So first you do the artery and the vein, and then the portion of the intestine left in the patient, the distal and the proximal ends are joined to the distal and proximal ends of the intestine. The major challenge why people don't do it, because just like a lung, it's a very lymphoid organ full of lymphocytes, and the rejection is tremendous. And the rejections can be very severe, because it's a very it's a bacterial loaded organ, and patients can well go into sepsis, and we can lose the patient. That is why it has not catched up, and it is not so popular, and they require much higher doses of immunosuppression as compared to a liver transplant. So there are a lot of immunological and sepsis related challenges. But yes, we have done now the 5 living intestine transplants. We are planning, we were even called, we helped the Singapore, they wanted to do their first living intestine transplants. Our team, Dr. Gaurav, went there, and we helped them to do their first living intestinal transplant. So probably we can proudly say that we are the only one who are teaching the world. No one in the world is even thinking of doing a. So that is one achievement which I also feel proud to be a part of such a team.
I'll just like to pitch in. So, as Dr. Rajiv said, so there are only 3 centers actually in the world who are doing it. One is in US. This is Living Donor LDIT, Living Donor Intestinal Transplant. So one of them is us. One of them was done in south of India, and another one is in USA. Am I right, Rajiv?
Yeah, but probably everyone has done 1 or 2 now. We are the only
we
one
have
now
done
doing
5. Yeah. So this child had a massive volvulus, and then he underwent a surgery where his entire small bowel actually was out. And the other indications I'll just read out. So it's NEC is one that we often come across in our pediatric population. Gastroschisis, omphalocele, which leads to massive intestinal surgery, and you have to resect a lot of intestine. Atrasias, volvulus, pseudo obstruction, and then there are two disorders like microvillus inclusion disease. In my life, I've only seen two of this, and then there's something called tufting disorder, which is again a very rare, small bowel problem, which happens mostly in the Western world, but maybe we are not picking them up. So these are some of them. And then, of course, there's something called CIPOS, chronic intestinal pseudo obstruction, where you do not see an actual obstruction. It's more of a neuropathognomic condition where we actually have done a transplants on them. But what our team is proud about is, doing it in the donor is a living donor. So it becomes challenging for our surgical team here. So pre-planning and, making sure, I think there is an adult patient who has actually come from Singapore. So we're getting a very good feedback, not just in pediatric world, but also from the adult. And as we grow, just like the liver, I think probably we'll have to, see how the outcomes, get better with time. Luckily, both of our pediatric patients are doing good. So yeah.
Great, great. This is something we had never heard, and we are so proud to know that there is a pediatric team that is doing it. I had a question. As the child grows, does the transplanted intestine also grow with the child, or it remains?
It does grow. It does grow. Just like it lengthens, and they are self-sufficient. They don't have any problem later on in the child adulthood.
So even that 150.
Yeah,
even that 150 centimeter, 100, depending on the child's age and, the donor's, kind of size and evaluation. So 150 is just good enough. The folds get better. The villi and everything gets better. So the absorption is good. So with the over the period of time, once the absorption, like in our case, also the Kazakh kid is still here. So now we see that, from the output post-op of 700, 800, it is just like minimal 200, and it is all form stool from that ostomy output. So even when you have to compare, we easily compare, okay, you do some, plus and minuses in the dosing, and, you can add some medications like Lometil to bring the output down. But then over a period of time, you get rid of all this medication and you see that it's mostly form stool. And that's where the time, Rajiv. So when do we reconnect the anastomosis now? Ostomy.
So just after the surgery, we do a temporary stoma so that we can do surveillance biopsies every week. And that is closed after 3 months. So after 3 months, he won't even have a stoma and completely normal. He'll look from the outside also, he will not look like he's having any stoma or managing the stoma. So that's just to do surveillance biopsies, because we do it even the biopsies are so difficult to read. Very few centers are equipped to read intestinal transplant biopsies. We have to send it to US and get multiple opinions so that we come to a consensus. So it's a challenge immunologically. That is the problem.
And the other thing that we did in this child is to have a simultaneous skin graft from the donor to the recipient so that we can pick up early rejection. Right? This is something that we didn't do into the previous child, but this child, we definitely did that skin graft, which was implanted on his foot, so that we pick up that early rejection if there is any.
Amazing. Thank you so much. Yeah, so it seems as if treating diarrhea has become so simple now. It's such a complicated thing. I was just wondering, so many children with diarrhea, what do we do? And now I know it's so easy. So it's okay. If they poop a little less or more.
I can tell you, anything to treat in a children is extremely difficult. And I'm sure even diarrhea are very difficult to treat.
The children are easy to treat, the parents are not. So, but something amazing, something very rare. And in keeping with the theme of the Rare Disease Month and Rare Disease Day, we've heard of very, very unusual cases of a CABG done for, familial hypercholesterolemia, Abernathy's syndrome, and as well as an intestinal transplant in a 6-year-old. So it couldn't have been better for this month, and also about a renal disease, a rare renal genetic disorder. And we had some stalwarts in this field. And Lalit, all this is being done at Global Hospital at Parel?
Yes. Yeah.
So this gastrointestinal team is at Global Hospital.
Yeah.
Thank you, Rajiv, for joining us and for telling us about these 2 cases. And please, we surely tell Gaurav we missed him, and all the best for his cases. So
Sure. Thank you so much. It was a pleasure.
yeah, thank you. And with that, we come to the final part of today's session, and that is about the common cases we are seeing, and Dr. Hemant Joshi will take it forth. Unmute Karava.
Yeah.
Yeah.
Yeah. Namaste and Jai Hind. Can you hear me all?
Yes.
Jayashri, is Jayashri around? Jayashri Deshpande?
Yeah, Jayashri is here.
Jayashri, are you there? Are you alive? She's alive or she's suspended animation? Whatever. We saw chicken pox. What is special about it? Jayashri told me that a 22 years boy got, or a girl got chicken pox and died. So
yeah, one of my acquaintance has got problem, and she was a 22-year young female. She was admitted in the hospital with proper care. She had a convulsions and she succumbed to the disease. It was neurologic CNS complications of chickenpox, and this may happen without rash also. And it has some latency period also, like so many years the virus can remain latent, and it can like show the symptoms after some years also. So this is a very dangerous complication of chickenpox.
Chickenpox.
Yeah.
And which is why they started the vaccination for chickenpox, although it was first initially said that it's a very common and benign childhood illness. But there were cases of kidney failure and CNS complications and encephalitis.
So that is why they.
The season is starting.
That is why they have started giving antiviral medicine, cyclovir, for all the cases of chickenpox to prevent that late complication, because the virus remains in the neurons for years together, and after a few years the patient can develop with neuroencephalitis like picture. So
Yes,
that's why it is very important to give a cyclovir for 5 to 7 days. Initially it was for 5 days, but now they have started giving up to 7 days also. And it is very tedious to give a cyclovir because the dose is very high. It is almost 15 to 20 milligram per kilogram 5 times a day. Because in adult it is 800 milligram 5 times a day. But there are some alternative antivirals have come out which can be given 3 or 4 times in a day.
I want your opinion on whether to revaccinate the children who received one dose only at the age of 1 year, or second year usually when we give chickenpox vaccine. So is there any need for a second dose after 10 years, or as they suggest, they have not received after 3 months of the first dose, we give the second dose? For those children, should we give a repeat vaccination?
No, you just have to give the second dose.
Second dose if they have not received?
The second dose, yes. And no matter how long back, because there is always an amnestic response. So whenever they have given the first dose, if they have not taken the second dose, we can give just the second dose.
At what age then?
Any age, even in adults.
Adults, we can give one dose then?
No, if they have received one dose in childhood, one more dose. If they have never received 2 doses 3 months apart.
They usually recommend at the age of 5 years. We give chickenpox initially 2 doses and then they recommend 5 years, but that is company's recommendation, but none of our IAP has recommended that.
IAP recommends 3 months after the first dose.
Yeah,
So
that is the routine schedule. Initially, it was only 1 dose which was given to young kids. Now they have advised 2 doses. So
Yeah, so
after 2 doses, it's a lifelong immunity, or you have to repeat after 10 years?
It's a lifetime immunity. Yeah, Dr. Hemant Joshi.
Sir, unmute kara.
Lifetime immunity naste, madam. After the vaccine also there are cases of chickenpox, but then the toxicity of that lesions are less.
See, I'll tell you. Hello.
Yeah,
I was lucky to I was lucky to do a clinical trial of measles vaccine when it came in India. I got James Flett Award for that. And I didn't know and both measles vaccine and mumps vaccine, they act similarly. So seroconversion is 95% or more with one dose. But the immunity is for lifetime, because whenever there is an epidemic or the virus is in town, our immunity is boosted, and this happens every year. And we still have a chickenpox in the country every year. So our immunity is boosted every year. We do not know which 95% people got the vaccine, so the second dose is good. And any one dose gives lifetime immunity. Number 2. Number 3, the vaccine is 2,000 plus per dose. For those who can't afford it, the best thing is to have a natural immunity at as younger age as possible. So in West, they would have chickenpox parties and mumps parties. So if anybody had a chickenpox at home, they would call all the children to play and have parties so that they get infected at the smallest age. Measles as well as chickenpox or mumps, when you get it in younger agehood, the morbidity is less. So currently we have to follow 2 strategies. One, recommend a vaccine to all, and those who can't take vaccines, ask them to go to a person who has got chickenpox and meet him today, so that today's age is better than tomorrow's age. So in 1 year, we can make India chickenpox free for the moment, or measles free or mumps free at any such given time. That was about,
but we don't know the immunological status of many children, so we cannot advise such thing to the common people.
You don't have to. We are so overcrowded, and we are so 1 lakh babies coming up every day. This happens automatically. We don't have to bring them together. We are already staying overcrowded, so you don't worry about it. I was just sharing them with chickenpox mom. Why we don't need parties? We are already so overcrowded. If one person gets chickenpox or conjunctivitis in Churchgate today, the boy in Surat and Pune gets it by the evening. Forget about the suburb. We all get it automatically. So let's not worry about it. And number 2, today we are talking on rare things. So I want to tell you something rare. And something rare is a good clinician.
Hemant, can I make one point about
Done.
chickenpox? Is
Yes.
that post chickenpox getting shingles or getting herpes zoster is known, and now herpes zoster vaccine is available called Shingrix, which is manufactured by GSK. They're going to come out with the vaccine in April. Shingrix or the herpes zoster vaccine to be taken 2 doses 1 month apart. That is because herpes zoster causes very severe painful lesions in adults. So it is recommended for all those who are above 50 years of age. I have taken when many years ago this vaccine had come by some other company. But I would recommend, the cost is little prohibitive. It's 11,000 per dose, but I think it is worth taking for anyone who wants to prevent zoster. Thank you.
Yeah, and we all who are listening to this today and are 50 plus and still alive, we all should take.
But at present, it's not available in India. Is it available in India? At present, it's not available.
जयश्री तुझ्या घरी येऊन जाईल मी सांगितलंय. Yeah, I was telling something else. How much time do I get? 5 minutes?
Yes.
Now, see, what has become rare is a good pediatrician. A pediatrician who has slept well, who is at peace. He had his time for exercise, yogasana, whatever in the morning. He had time for his breakfast. And he came smiling, and he wore a freshly washed clothes and a freshly washed apron. We learned it in COVID that we should use disposables, but we use the same apron, the same tie, the same whatever. So when we go home, we should enter a bathroom and then have a bath and discard things every time. Then we have taken Hippocratic oath that I treat every child as my own child. We should put this in the clinic in front of our eyes. It changes our behavior. We have made it into Marathi and Hindi and simple English, so we'll send it to you. We have printed hard copies as well. Then now I'm very serious. a healthy child has become rarity. And we are blinded with, we think that our standard for a newborn, normal newborn is 2.5 kilos. So we have made our standards low. A normal newborn is 3.3 kilos, not 2.5 kilos. If we take a child at 2 years, the NFHS 5 data says that 9 out of 10 are undernourished at 2 years. So 90% of India's children are bad at 2 years. 35% have iron deficiency anemia. 55% have calcium deficiency, all of us. Majority are B12 deficient. So now where is the normal child? If you look at 5 years child, every second child has caries teeth and we never see them. Most newborns have edema. Their eyes become little puffy, or their umbilicus is flat. Or if we see edema of it, we find it there. But we don't see edema of it. So, let's try to strive to make good babies. Dr. Desai was telling me yesterday that every third lady who comes for delivery is obese and has diabetes of pregnancy. So our girls are bad. So let's try to make India healthy. Thanks for listening. Nobody listens to me. It's okay. Grateful to you. Thank you.
When you spoke of obesity, Dr. Hemant, this Sunday on the 12th of March, we are having an event on Obesity Day. World Obesity Day is observed on the 4th of March every year. And in lieu of that, we are having a small session where whole body composition will be studied, bone mineral density, and a scuba session for the family. And then talk, and two of our stalwarts are going to speak on that day. Dr. Hemant Joshi will be speaking on normal diet, and Dr. Jayashree Deshpande will be speaking on introducing millets in our diet. So please do attend. This will be at Vasai Bal Bhavan, and it's in with IMA Vasai and Bal Bhavan Vasai. So that's because of children are obese, and obese children come from obese families. And so I will be putting up a poster for this event.
Anjali, make a poster, my city, obesity.
Sir, epidemiology wise, we are talking about epidemiology. You are talking about chickenpox. We are seeing lots of adenovirus. The adenovirus has gone down now. Adenovirus is behaving like a bacterial virus, bacteria itself, because there is lot of slough on the tonsils. The CRP is very high. It goes in 100 to 200. All of this with respiratory symptoms, with pulmonary, means like rhonchi, crepes, everything is there. Malaise, everything. But now the adenovirus has gone down. Now this H1N3 means we are doing regularly biofire in our patients. We have started doing biofire in our patients with respiratory symptoms. And we have started isolating H1N3 in our patients with lot of rhinorrhea and lot of cough, dry cough. But this H1N3 does not have tonsillar enlargement, or there is no slough on the tonsils, which was there. Adenovirus had lot of conjunctivitis, which there was eye swelling, which is not there with H1N3. It is more of rhinorrhea, more of sneezing, more of fever, more of malaise. So the change what we are seeing is from adenovirus to H1N3 in last 1 month time. And this H1N3 affects more of small kids rather than bigger kids. Bigger kids have started becoming a little less, and smaller kids have started getting affected more. So this is the
epidemiology. A lot of gastroenteritis with cough and cold. And
so that is H1N3. That is H1N3.
In
Great
Mumbai,
job,
Shailesh. They have found that H3N2 is more common rather than H3N2.
Madam, start doing biofire.
Yeah.
Start doing biofire. It means it keeps our heart at a peace. We can explain to the relative that this is the virus and this is so bad, and relatives, many of them are Google people, and they read about the adenovirus, and adenovirus is really dangerous. I had gone to Jupiter Adenovirus had meningoencephalitis, adenovirus had Guillain-Barré syndrome, adenovirus had many deaths. One of our patients died after 15 days of ventilation. So it is bad. So from that time onwards, we have started doing BioFire and it really helps you out. It is costing a little bit more. Chinese kit is costing somewhere around, for poor patient is 6,500 from infection lab. But Biomurex kit is costing 14,000. But we have requested Dr. Mopkar to start the kit at his lab, and he'll be starting somewhere around 8,000, 9,000 rupees.
Thank you.
But
Well,
if we put up more samples, at least the cost of the
Cost will go down.
Cost will go down.
Yeah, Hemant.
Yeah, Shailesh, well done. चांगलं सांगितलं. Thank you. We all are grateful.
Yeah.
Treatment wise, do you prescribe any antiviral or any other medicine which are like specific
We
for?
usually give Fluvir, and we also give antibiotics because adenovirus has lot of secondary infection associated with it, and only on Fluvir usually they don't come out. I have talked to Dr. Prabhu. He says that I don't give anything for 10 days, and I tell my parents to wait for 10 days, but I don't have so much of patience, and our patients don't wait for so many days. So with at least some medicine, they get prolonged, and ultimately it gives better in 10 days, but we cannot answer the queries for 10 days.
So after 2 weeks, you advise vaccination for flu.
Yeah, we advise them vaccination, but they take or they don't take. It is a matter of question. Even those who have taken vaccination of flu, influenza vaccine, they also get sick. So usually, I don't know how much that flu vaccine really helps.
No, that's because our vaccination rates are very low, and I think we should all increase it. And with that, I just wanted to say that some of the vaccines for us as doctors above the age of 50, we should take a Tdap every 10 years. We should take a Shingrix vaccine in 2 doses. We should take a pneumococcal vaccine, and there was one more vaccine I thought of. If we have, in our families, the nanovalent HPV vaccine, including the boys.
President, keep one camp at your home with idlis and vaccines.
Most welcome. आज पण इडली आहे, या तुम्ही.
Okay.
So I think we should inform our colleagues to take Tdap, pneumococcal, flu vaccine, and Shingrix. And can we call it a day? So
yeah,
the things that are measles are still coming in crops.
So we all meet on April last Sunday at Dr. Joshi's house for a party and all vaccines, all missing vaccines for all pediatricians. असं केलं तर होणार, नाहीतर नाही होणार.
चालेल.
Done.
So this month we have one more event for World Down Syndrome Day. Dr. Shruti Bajaj and I Palghar. I spoke to Vaibhavi today morning, and we are having on the 21st online session for Down syndrome on 2 issues. I will put that poster, and on 26th, all children with Down syndrome and orthopedic problems will get a free checkup by Dr. Chasnal Rathod. I will put that up also. That is on behalf of IAP and PEHEL. And on 12th, we have it for World Obesity Day. So for this month and our next CME Vaibhavi, I think we can decide and then inform everyone. We had a very good participation. We had 46 participants, and most of them have stayed on till the very end. Thank you everyone for joining in on this afternoon.
Wait. Can I say the same link will be operational all times so that our people, you have to only pay 100 rupees if you want the MMC credit, because MMC takes that money. Yeah. Otherwise, the same link, they don't have to ask every time you get 50, 100 calls.
No. The link we will share every time. So, Hemant sir, I will give the link one week before.
Okay. पुढच्या महिन्याची लिंक उद्याच तयार करून टाकू.
चालेल.
Not on the last day. म्हणजे मग that will reduce your calls.
The link was prepared 1 week ago. I had put it on the group 1 week ago.
नाही ओके
Yeah. Thank you.
आम्ही
Thank
असेच
you.
गाडावर काय bear with us. Okay.
Thank you, Anuradha, for getting us the MMC points. Anuradha, the man works behind this. Thank you, Vaibhavi, for starting the event. Thank you, Shailesh, Jayashri, Hemant sir, for being present.
Hey,
Thank
I want to tell you something.
Yeah.
8th March 1917, Russian women came on streets and protested and said, we want bread and peace. But they got up as bonus voting rights as well. So we celebrate 8th March as Women's Day. So, तुमचं सगळ्यांचं अभिनंदन.
Thank you.
New Durgas. Okay.
Thank you, Hemant sir. So,
Okay.
everyone who joined, thank you, Vaishali, Shruti, Lalit Verma, Rajiv Sinha for having joined in, and Dr. Hemant Joshi for conducting this. Thank you everyone for attending. And we meet again, the date will be declared. Please do come on the 12th. The 12th, a nice session. There's going to be some Zoom. And also there will be good talks by Jayashri. Please do come. Shailesh, तू पण
Yes,
यायचं
ma'am.
झुंबा करायला.
Yes, ma'am.
फक्त हिमालय चढून चालत नाही.
YouTube लाईव्ह बंद करू मम्मी.
IAP हा हो पल्लवी.